So breast cancer is a major public health issue and poses significant challenges. It has now surpassed lung cancer as the first leading cause of global cancer incidence among both sexes. And according to the Global Cancer Observatory database, in 2020 we had 2.3 new cases, accounting for 12% of all new cancer cases. Whereas in terms of mortality, breast is the fifth leading cause of cancer mortality, with 685,000 deaths in 2020. Nonetheless, the high incidence rates do not correlate to survival rates. In fact, in the last 2 decades, breast cancer survival has been steadily improving. And according to the latest data from the SEER database, the 5-year relative survival for breast cancer is 90%. And if we look into localized disease, which is the majority of cases that we see nowadays, the 5-year relative survival is almost 99%. And Europe follows a quite similar pattern. You can see that there are some countries like Cyprus, where I have the privilege of working, that there is a reported survival of 92%. So we have great improvement in survival. And of course, this is due to a number of factors. We have better detection of cancer, we have great adherence of women to screening guidelines, we have better coordination of care, we have advanced systemic treatments, better surgical treatments. So we are dealing with a great number of survivors. And let's start with the basics. Who is considered to be a breast cancer survivor? According to NCCN guidelines, a cancer survivor is the individual from the date of the diagnosis and throughout his or her life. And the survivor is not only considered to be the person free of disease, but also the person living with cancer. And when we try to design a survivorship plan, we have to think of 4 pillars. The first one is how to coordinate the care. The second, which is very important, is to early detect any signs of cancer recurrence or cancer spread. The third pillar is to monitor long-term effects from past or active treatment. And of course, we should never forget that our aim is to promote health in general. So let's start again with the basics. How to better coordinate care. According to the National Accreditation Program of Breast Cancers, a survivorship care plan should be handed to a patient at least 6 months after completion of active treatment, but no longer than 1 year after the date of the diagnosis. And what does this care plan should consist of? Of course, the patient's cancer history, whatever transpired during cancer treatment. What is the active treatment that the patient is going to have? For instance, endocrine treatment. Recommendations for follow-up visits. How often should they attend the clinic? Recommendations for testing, any examination that needs to be done. And of course, support services. We should have a roadmap for our patients. When I was preparing this lecture, I found some very interesting resources, and I advise you to look them up and start using them for your own practices. So one very interesting resource is the one from ASCO. You can see that they have a very detailed form when we want to design a care plan. One other very nice one is this one from the College of Family Physicians of Canada that I'm going to get into detail later in my lecture as well. So as you can see, the first page always has the details of the patient, the medical team responsible for the patient, the treatment that he or she has had, the active treatment that we are going to have. So we don't have to mess our lives. We have people that have thought ways to make our lives easier, and of course our patients' lives easier as well. Who is responsible to prepare the care plan? The healthcare professionals coordinating cancer treatment, of course with the input of other care providers. And one very important aspect is that this survivorship care plan should be discussed with the patient. We have come to an era of shared decision making. And when the plan is prepared, it is handed out, of course, to the patient, to any caregivers, to the primary care physician, and any other cancer or non-cancer related practitioners that might be in contact with the patient. And now, let's start with these important pillars. What about cancer surveillance? First of all, we have to make a plan of how often does the patient come to the clinic for a follow-up. For the first 3 years, the follow-up takes place every 3 to 6 months, and then we switch to every 6 to 12 months, and thereafter the follow-up visits can be made annually. These are guidelines from ASCO. What happens during these visits? We take a detailed history and we perform a clinical examination. And most in detail, we ask our patients about symptoms or signs that could be alarming for a recurrence. We explain to our patients what to expect regarding the treatment they are taking. We make sure that the patients adhere to the treatment. This is something very important. Particularly for endocrine treatment, young women have a low rate of adherence to treatment. So we have to make sure that they actually take the treatment that they have been prescribed. And also, according to what we see, we may adjust recommendations because guidelines are there for us to guide us, to advise us on what to do, but we can always deviate from that plan according to what our patient has. We are talking about individualized care. And one other thing that we should remember, sometimes we take it for granted that the oncology team has already thought about that, but maybe they have not. So we have to think if the patient's circumstances have changed and there is a necessity for a genetic referral. So, which are the reasons to refer a patient to have a genetic test? If the patient has been diagnosed with breast cancer at a young age, they say younger than 50, but at least for patients that have been diagnosed with cancer younger than the age of 40, it is necessary to refer them, provided that the patient agrees with our plan. If the patient has been diagnosed with triple-negative cancer younger than the age of 60, if they have had bilateral breast cancer, if they have had breast and ovarian cancer at any age, multiple relatives in their families with breast or ovarian cancer, male breast cancer. So we always have to reassess the status. It is necessary. All right, so what do we have to remember? Again, I go back to this survivorship tool from the College of Family Physicians because it is very clear and it is easy to remember and go back to. So when we are talking about recurrence, we have to think of breast and chest area, brain, lungs, liver, bones. So in terms of breast, we ask our patient, we examine our patients for new breast masses, for new axillary masses, skin changes, nipple changes. We know that. If we have any of these findings, we have to decide on what type of test we can do. Either a mammogram, an ultrasound scan, maybe sometimes we might need an MRI, depending on what findings we have. In terms of brain, if the patient complains of new onset of headaches, nausea and vomiting, seizures, numbness, paresthesia, we have to order some scans to check what is happening or referral to the oncology team. As you can see, in these countries like Canada, USA, survivorship is being taken care of the primary care physicians. In Cyprus, in Greece, and in several other countries, the oncology team takes care of the patient for many years. So, in terms of lung, if the patient complains of cough, hemoptysis, shortness of breath, we should order a chest X-ray, a CT scan, and refer to the medical oncology team. In terms of liver, abdominal pain, abdominal distension, fluid, jaundice, again, we should order some lab tests, some imaging tests, and refer back to the oncology team. And in terms of bone metastasis, any complaint of new or progressive, localized or generalized bone pain should be alarming. Now, we go back to breast recurrence, because this is very important. How is breast recurrence monitored? It is monitored through a mammogram. How often should we have a mammogram? The mammogram should be done on an annual basis, and we usually start 6 to a maximum of 12 months after completion of any treatment. If the patient has had a wide local excision, we do a bilateral mammogram. If the patient has had a mastectomy, we do a mammogram of the intact breast. And why do we choose mammogram? It has been shown after multiple studies that this is the gold standard to detect either ipsilateral recurrence or contralateral breast recurrence, because this is an issue as well. And it is very important because we have a way to have a baseline of post-radiation or post-treatment changes. We have a way of early detection of either residual disease, remember what Professor Durande had shown us yesterday, or recurrent disease, and in that way we can have better survival among all ages. Now, what about further imaging? And I'm starting with ultrasound scan. Ultrasound scan is not mandatory. It can be beneficial in some cases, like patients who have dense breasts, but we have a bit of mixed data when we look into research. And I have chosen 2 studies to see the mixed data that we have. So this is a single center retrospective study from Australia. They looked into the role of a supplementary ultrasound scan for breast cancer recurrence. So what they saw is that the sensitivity, this is the wrong number from the authors, it is 44% compared to 21% of the mammogram. The specificity is quite high, 95% compared to the mammogram. The positive prognostic value is similar. But the problem with the ultrasound scan is that it generates a large amount of biopsies. And this is a problem because it increases the surveillance costs. And the cost is increased, but the survival is not improved. There is an argument on that. Okay, you say that you increase the cost of surveillance. But on the other hand, what if we detect cancer recurrence at a later stage, which means that we add cost to the healthcare system with adjuvant treatments. And of course, we should always remember the ramifications for our patients to have an early detection of recurrence. Also, this is a retrospective study, so we have selection bias. So this is a way that you should always think when you read research. You always have to keep in mind how to assess the data that they show us. Another retrospective study, a single center study from China. This is a better study because it's a matched cohort study. This means that they found patients that have a personal history of breast cancer, equal number, similar characteristics of patients with a non-personal history of breast cancer, and they compared the results. So they had about 3,000 women in each arm, and what they found is that in patients with a personal history of breast cancer, they detected 14 cancers. One important thing is that out of these 14 cancers, 8 of them were interval cancers. Whereas in patients from the general population, they detected 13 cancers, 12 of them screen detected. Out of these interval cancers, in patients with a personal history of breast cancer, most of them were of higher grade, HER2 positive, triple negative. So there is a question that second cancers may present with a more aggressive behavior and rapid growth potential. So systemic treatments might prevent recurrence from cancers that are susceptible to that treatment, but they might allow recurrence from cancers with another type of progression. And in these cases, the ultrasound scan seems beneficial because, as you can see here, it improves the rate of interval cancer detection. So the data that we have are from retrospective studies. These are considered not very high in our chain of research, but there is evidence that we have to look into which categories of patients might benefit from an ultrasound scan. So we should not say that, no, we never perform an ultrasound scan, but we should be open to suggestions. What about an MRI? An MRI is advisable in high-risk patients. And high-risk patients are those who have a more than 20% risk of a new cancer. These patients are the ones with a known gene mutation and the patients with a very strong family history that haven't been tested. And in this population, MRI has a better sensitivity compared to two-dimensional mammography and breast tomosynthesis, a slight less specificity, but it detects more cancers compared to a mammogram. Now, apart from the non-high-risk patients, there is a question of the use of MRI in people with dense breasts, but we should not perform MRI as a standard if we don't have high-risk patients. Another important aspect is that depending on the surgery that the patient had, we might use different type of examination. So in patients that have had a mastectomy alone, without reconstruction, a clinical examination is thought to be sufficient. If we have any finding, then we can perform an ultrasound scan, and in rare cases, an MRI might be considered useful. If the patient has had a reconstruction, again, we perform a clinical examination, and if there is any finding, we do usually an ultrasound scan. A mammogram can be useful because these patients can have calcified oil cysts, but usually an MRI is more advisable. In patients that have had an implant reconstruction, we should remember of some issues that we might be dealing with, like contracture. This can be easily seen with clinical examination. Rupture. It is very interesting that FDA has advised that every patient that has had an implant reconstruction after mastectomy, they should have a non-contrast MRI, the first one at 3 years, and then every 2 years to detect for rupture. And one other thing, which is rare, but we should be aware of, is the implant-associated anaplastic large cell lymphoma. If we have a patient that presents with persistent or new onset of seroma, we should do an ultrasound scan, aspirate some fluid, and send it for cytology, but we have to say to the cytology department that we are looking for this entity, because they look for specific markers like CD30. Now, what about autologous reconstruction? Clinical examination is quite good. If we have findings, we can use an ultrasound scan or a mammogram as well, because they are useful in this type of reconstruction. When do patients who have had a reconstruction recur? If there is a skin-sparing mastectomy, the usual site of recurrence is between the skin envelope and the autologous tissue. In these cases, a clinical examination might be enough. If they have a chest recurrence, a clinical examination, as you can understand, is not quite helpful. So in these circumstances, we need imaging. Ultrasound scan, probably we will require an MRI in these cases. Now, we said that we start breast imaging 6 to 12 months after completion of treatment on an annual basis. Do we ever stop? Guidelines say that if our patient has a good life expectancy, we don't stop, because a mammogram can save lives even at an older stage. So if a patient has a life expectancy of at least 5 to 10 years, and the patient, of course, agrees with that plan, we can continue imaging for breast recurrence. Now, another issue. Do we need to perform lab tests or other imaging tests, such as CT scans, PET scans? No. Why? Because it has been shown that not only do these tests increase false positive and false negative rates, but most importantly, they do not add anything to survival. So, if we want to follow the guidelines, we do not offer any routine tests to our patients unless we have symptoms or, of course, unless we are dealing with very advanced disease. Now, another important aspect, long-term effects of any treatment. Again, I have used this tool from the Family Physicians of Canada. We have to think from head to toe. So what can go wrong after treatment? Chemotherapy causes cognitive dysfunction. Any type of cancer treatment, even just surgery, causes emotional distress. Chemotherapy, particularly anthracyclines, trastuzumab, can cause problems with the heart, such as arrhythmias or myocardial infarction. Endocrine treatment can cause hypertension. Radiation treatment can cause fibrosis. So if the patient has a shortness of breath, we should think of recurrence, but we should also think of any side effect of the treatment. Endocrine treatment, and particularly tamoxifen, can cause a fatty liver in up to 30% of the patients. Tamoxifen, again, is associated with an increased risk of deep vein thrombosis and an increased risk of pulmonary embolism. So when we start a treatment, we should advise our patients of what to expect and what to consider as alarming. Now, again, endocrine treatment, and particularly aromatase inhibitors, can cause problems with arthralgia, musculoskeletal symptoms in a lot of patients. And another important factor is that even if the patient has just had surgery, there is a number of patients that present with chronic pain, even with just lumpectomy. And, of course, in terms of surgery, we have to remember of lymphedema. Even if they just had sentinel lymph node biopsy, there is a risk of up to 9% of having a lymphedema. This percentage, of course, goes to up to 40% if the patient has had axillary lymph node dissection and adjuvant radiotherapy. Patients who are on endocrine treatment often experience problems with their personal sexual life. They complain of vaginal dryness, discomfort during sexual intercourse, and of course, patient who has just treatment because of breast cancer may be discomfortable with intimacy. So when we see patients in our clinic, I'm not going to go into detail because I don't want to bother you with too much detail. We should be close to our patients, advise them on what to expect, give guidance. We have simple tools that they can use and improve their quality of life. We might need to use further treatment to help them, but we should always monitor what can go wrong. Because if the patient has side effects from the treatment, this is a reason to stop the treatment. And last, but certainly not least, is health promotion. One very important thing that we might forget is that a breast cancer survivor can always have another type of cancer. So we should have a plan of screening for other cancers, such as colorectal cancer or cervical cancer. Now, in terms of general health, it is advisable that our patients follow a balanced diet, which is rich in fruits, legumes, grains, low on non-saturated fat, low doses of processed meat. Patients should usually not take supplements or iron unless they have a deficiency, and usually they need calcium and vitamin D because of the endocrine treatment. In terms of physical activity, it is important to urge our patients to go back to physical activity as soon as possible. And they say that they should do about 150 minutes of moderate exercise on a weekly basis, or 75 minutes of more intense exercise. And now they have added muscle training as well, twice on a weekly basis. What else? If our patients smoke, we should advise them to stop smoking. It increases their chance of survival. And in terms of alcohol consumption, it is advisable to consume less than 3 or 4 standard drinks on a weekly basis. So, where do we want our survivorship care plan to go? We aim at designing an individualized care plan that empowers patients. It gives them control of what is happening. Of course, we need to early detect any signs of recurrence, because in that way, we will be able to achieve a better quality of life for our patients. We have a holistic approach, and one very important aspect that is different from the past is we do not rely on measurement of clinical activity, but we rely on what the patient reports. I'm sure that you have heard a lot of patient-reported outcomes, so medicine is shifting towards this approach. So, thank you very much. I am open to any questions.